Hello, good morning, everyone. Today, we are honored to have this interview with Prof. Kerr. He is one of the world's leading voices in cerebral palsy and spasticity care, known for turning complex movement problems into clear evidence-based treatment plans. He has helped shape how teams use clinical gait analysis, timing, and single multi-level surgery to improve function, not just in lab, but in real life. In this interview, we go beyond Botox versus surgery to unpack what truly changes outcome in children with CP, the right intervention at the right time for the right child. Good morning, sir.
Good morning. My pleasure.
Thank you. So let's warm up with just the first question. What do people get wrong about spasticity in CP?
That's a great question. I would answer it by saying that my own views on the importance of spasticity and the role of spasticity have changed over my working lifetime. When you start regularly examining children with cerebral palsy, of which the spastic form is the most common, it's it's a very tactile sensation. You cannot help but be impressed by its presence and its pervasiveness, its consistency. It feels to be a strong force, often feels to be some degree of a malignant force. And when you feel, for example, the spasticity in the hip adductors of a younger child when you try to abduct the hips, and you feel that strong adductor spasticity, and then later there are contractures, and then later still there is a dislocation of the hip which may become painful. It's very easy to assume that this is a linear sequence: spasticity, contracture, dislocation, pain. But really, it's not as simple as that. I think that in general, spasticity has been overly, the importance has been been overstated, and therefore it's not just of academic importance, because many attempts to treat spasticity have had less impressive outcomes than you might expect. So, for example, if we take two of the very common interventions for spasticity, such as injections of botulinum toxin, commonly known as Botox, or something much more invasive and more effective, like selective dorsal rhizotomy, neither of those interventions have had anything close to the functional benefits that we would have expected. And I think it's fair to say that most of us have been disappointed in these interventions. It's both interventions, if you examine just the evidence for reduction of spasticity, there's randomized clinical trial evidence that both are effective in reducing spasticity, but the functional benefits and the downstream benefits, such as breaking the link between spasticity and deformity, the evidence there is very much less. And there is rapidly evolving evidence, some of it only published in the last 12 months, that, for example, selective dorsal rhizotomy does not, contrary to expectations, change the need for subsequent orthopedic surgery in ambulant children with diplegia. And that's very important, because one of the reasons why we have used Botox and why we have recommended rhizotomy was to have fewer contractures, less deformity, and less need for orthopedics. And that really hasn't eventuated. So the fact that it hasn't led to the desired outcomes is a disappointment, but it's also an opportunity because to me, it raises the fundamental question that perhaps spasticity is not the number one cause of deformity. It might contribute a little bit, but it's not the only cause, and treating spasticity, unfortunately, will not prevent deformity.
That's very inspiring. So is that lead you to further research to understand like what is causing the deformity?
Yeah, it's caused a really substantial rethink. One of the most common problems in the cerebral palsy population is hip displacement, and it particularly affects the non-ambulant child. And it's a really difficult problem to manage. Because we have a cerebral palsy register in Melbourne and in Victoria, we're able to look at population-based statistics, and we were able to demonstrate that up to 90% of children at GMSCS level 5 will have some degree of hip displacement, and that there's a very direct relationship between GMFCS level and the risk of hip displacement. So it's almost zero at GMFCS 1, and it's close to 90% at GMFCS 5. Now, the reason for that is not progressively increasing spasticity, because the figures for spasticity don't correlate with the figures for hip displacement. So in recent years, we have begun to understand that there are positive and negative features of this upper motor neuron syndrome. And it's very understandable that we have tended to focus on the positive ones, because when I examine the child with severe cerebral palsy, the hypertonia and the hyperreflexia stand out. But if we were to take that away, underneath it would be profound weakness. And cerebral palsy means weakness coming from a cerebral cause. It's not cerebral spasticity, it's cerebral palsy. And so when we take away spasticity, we're left behind the negative features, which are weakness and loss of selective motor control and other features. And in recent years, we have begun to concentrate on these negative features. And it's not just academic, because we did a 3-year randomized trial of Botox injections to the hip adductors and the hip hamstrings to see if we could reduce hip displacement. And it had no effect of any material significance. But then, as we were looking at these children and following them up, we could see that the shape of the femur was significantly abnormal. There was both a coronal plane deformity of coxa valga and a transverse plane deformity of increased femoral neck end eversion. So we did additional studies and publications on what we call proximal femoral geometry, and the more plausible explanation that the shape of the femur is markedly abnormal, contributing in a major way to hip displacement and hip dislocation, just as shown here. So for the first half of my career, I focused on the left hand pictures, the loss of inhibition and the positive features, spasticity, hyperreflexia, clonus, co-contraction, and botulinum toxin impacts all 4 of those. I mean, I injected Botox in the hip adductors. 1 week later, the child feels more relaxed. The range of abduction is increased. But we forgot the problems on the other side: weakness, impaired selective motor control, poor coordination, sensory deficits. And those impact on problems such as hip dislocation. And the management of hip dislocation requires, in general, correction of those effects of the shape of the femur. So correction of the shape of the femur by well-conducted, well-planned bony corrective surgery is much more effective and much more important than just reducing tone.
That's very interesting. And this would lead us to moving to the next question. So when you decide it is time for surgery, what would be the red flags that therapy or Botox alone won't be enough?
It's another excellent question, and I think it's an unsolved problem. Botulinum toxin was pioneered in North America by a colleague of mine, Dr. Andrew Komen, and he in fact should be credited with the very first publication. So as an orthopedic surgeon, he wanted to investigate the potential for injections of botulinum toxin specifically for the very common problem of spastic equinus. I conducted around the same time very similar studies, and our investigations proceeded in parallel, and we both found that botulinum toxin could reduce spastic equinus if you chose young children with pure spasticity and no contracture. But orthopedic surgeons tend to be good because it's in our DNA at recognizing contracture. Nowadays, botulinum toxin is injected far more frequently, not by orthopedic surgeons. Some orthopedic surgeons do use it, but for the typical child in Australia, the child may be examined and selected for botulinum toxin injection by a physiotherapist, and the injections in Australia are more likely to be done by experts in pediatric rehabilitation. And in the United States, these specialists are generally called physiatrists. And they have a very good skill set, a very important skill set that is complementary to orthopedics. But I find with frequent interactions with such colleagues that I think that their skills at recognizing the slow transition from pure spasticity, then a period when the child has a mixture of spasticity and early contracture, and then a full-blown contracture, that is more nuanced and more difficult. And I guess we like to dichotomize things. Flexible spastic muscles can be treated with botulinum toxin. Fixed contracted muscles are better treated by muscle tendon lengthening. But in truth, many children are in the middle and have both spasticity with an early contracture. So it's when fixed contracture starts to develop, that's a red flag, because another important caveat is that in the early days, we thought that using botulinum toxin, I often stated this to parents when we were considering injection. I said, well, there might be an early contracture, but it's not going to do any harm if we inject again, and we'll know then it's almost like a test for contracture. And if it's the wrong intervention, then next time we'll go with an orthopedic intervention. So this was popularized by one of my mentors, the wonderful, gifted Dr. Mercer Rang. He was an orthopedic surgeon in the Hospital for Sick Children in Toronto. And this is one of his many beautiful illustrations where he wanted to simplify things. And so stage one, spasticity, dynamic contracture, consider physical therapy, orthotics, botulinum toxin. And then it becomes fixed and you need to do some form of orthopedic surgery. But the truth is between 1 and 2 is a transition period, and many children have a bit of both. And so although the the caricatures, the cartoon drawings here are still very useful, and I use them all the time in teaching. I also remind the audience that stage 1 and 2 are not discrete, not entirely separate, and it's important to recognize the transition. There are some relatively simple tools called the Ashworth scale is the most widely used scale for spasticity and is a little bit useful. It's quite simple, but it's not very discriminatory. And there is a better tool called the modified Tardieu scale, in which, for example, at the ankle, you examine for the degree of equinus quickly, deliberately to provoke a stretch reflex. That's called R1. And then you do the same maneuver, but much more slowly to avoid the stretch reflex, and that is R2. And if you can examine accurately for R1 and R2, you will have a much better feeling for when you might use botulinum toxin and when you might use orthopedic surgery.
I think this is quite a wide gray zone, right?
Yeah, I agree. It's a gray zone, and although the Tardieu scale and the Tardieu test are not all that difficult, they do require a tactile feeling, and they require to be done carefully and in a standardized way. And I think that these tools need a better understanding. They need to be more widely taught, and and practitioners need to evaluate their practice for their accuracy and their reliability.
I see. And can I just check, like, for this CP registry in Australia that you have mentioned about, like, how did it get evolved? Like, is it like a well-established referral system from the pediatrician, or how did it get evolved?
Well, I came to Australia in 1994 to a very large children's hospital with a very, very impressive group of orthopedic surgeons. And many of them had subspecialty interests. So we had surgeons who were experts in the pediatric spine. We had experts who were excellent in managing hip disorders. Some were experts in managing children with orthopedic manifestations of genetic conditions, and some were experts in limb reconstruction. Some focused on foot and ankle surgery, but there was no one who really specialized in the orthopedic care of children with cerebral palsy. Everyone did a little bit, no one did a lot, and there was no gait laboratory, so there was very little objective measurement of what was happening. And at best, the evidence that we had in those days was fragmented and incomplete. So I was hired and invited to come to the hospital to open a gait laboratory because some of the surgeons, especially the late great Malcolm Menelaus, who was a world expert in myelomeningocele or spina bifida, had recognized that it was time to measure gait objectively. So I think that when we opened a gait laboratory and we moved very simply, and we established a rule, which was that ambulant children must go to the gait laboratory before any orthopedic surgery. And the reasons for that were to improve our diagnostic and evaluation abilities, but also to improve the evidence base, because every child who was going to have a preoperative gait analysis was also scheduled for an automatic further gait analysis 12 months after surgery and 5 years after surgery. And that has become our routine plan, and it's routine practice. So all of the children, preoperative evaluation, postoperative evaluation at 1 and 5 years, short-term and medium-term follow-up. And very, very quickly, we were able to learn what was working. We were able to learn what procedures tended to produce undercorrection. And much more importantly, we learned which procedures carried a risk of overcorrection. And we then, through the influence of one of my colleagues, Dr. Paulo Selber, he introduced a very simple concept, which really was a very good parallel with botulinum toxin, because one of the first questions when you evaluate a child who has spastic equinus is, which is the target muscle? Is it the calf muscle, the gastrocsoleus, gastrocnemius, soleus, or gastrocnemius, soleus, and maybe hamstrings? And then what dose of botulinum toxin should be used? I mean, that's the standard way to approach medical treatment, the dose of the drug and the frequency of the drug. Well, Dr. Selber introduced the concept into CP surgery is of what is the appropriate dose for this child. And I took that up enthusiastically because I could see that, for example, for children with equinus, lengthening the Achilles tendon at the level of the tendon was very effective for children with hemiplegia. It was usually the right dose for them, but for the majority of children with diplegia, it was too big a dose. And many of those children, we published the results, had an unacceptable risk of overcorrection into calcaneus. Now, residual equinus or recurrent equinus is really quite easy to treat. And this, thank you for putting up these illustrations at exactly the right time. So our original concept was that if the calf muscle was like a spring, we could inject botulinum toxin that would relax the spring, and then we would have complete recovery. That's no longer what we think. In fact, we now believe that there is a small permanent effect in the muscle. It's especially the evidence for this is particularly strong in animal models, but there is evidence from imaging the gastrocsoleus non-invasively with non-ionizing modalities such as ultrasound and especially MRI. There is some evidence for increased connective tissue, and in fact, not only may botulinum toxin not prevent contractures, but there is some evidence, and we are continuing to evaluate it, that we actually in the longer term may contribute to more contractures or recurrent contractures. So we no longer feel that it's wise to continue botulinum toxin beyond a very short period of intervention, and that we should stop quickly if it's not working. We should reevaluate, preferably go to the gate laboratory and have sophisticated measurements made, and then proceed to muscle tendon surgery. So the window for botulinum toxin, we think, is now much shorter, much narrower, and we're quite happy to wait for another couple of years without any intervention before we proceed to muscle tendon surgery. It goes back to something you said. We believe that pretty much everything in cerebral palsy works for the right child at the right time, but nothing works all the time. Not botulinum toxin, not rhizotomy, not orthopedic surgery. So the art is choosing the right intervention for the right child, and really timing is really important.
Thank you so much for your elaboration. So this will lead us to the next question, because you talked about the gate lab which you established once you moved to Melbourne. So what's the one gate lab inside that changes your plan most often?
It's different. Oh, so I'll give you a little bit of background. I only be my first interest in gait analysis was when I was in my very early days in the late 80s and early 90s and was starting clinical trials of botulinum toxin. I kind of thought, well, it's not going to be good enough to just have videos. It's not going to be good enough in clinical trials to say the children look as if they're walking better. I need objective measurement. So my first entry into gait analysis was I want to measure the specific outcome of an intervention injecting the calf muscle with botulinum toxin. But the moment I started to spend time in the gait laboratory, and as soon as we opened our first gait lab, I spent at least a half day per week, usually a full day a week in the gait laboratory. And the moment I started looking at the wealth of information that comes from a gait lab evaluation, I said, well, this is an important way to measure the effects of botulinum toxin or selective dorsal rhizotomy, but it's much more important for orthopedic surgery to plan the right treatment, to choose the right dose of orthopedic surgery, and then to evaluate the outcome. So within a few months, I changed my pattern of referral from mostly children to measure the effects of botulinum toxin to a much more balanced referral pattern of all of the children who need orthopedic surgery because the intervention is bigger. Orthopedic surgery, it has a greater risk attached of overcorrection and over lengthening, and therefore I really want to know if we're doing the right thing. So 1994 is the year that I came to Melbourne. 1995 was the year we opened the Gait Laboratory. And pre-1994, my colleagues relied on observational gait analysis, watch the children walk, preferably in the corridor, and even better, record a video. Pre-1994, the practice was single level surgery. The surgery for Aquinas was the Achilles tendon. The type of AFO was usually a hinged AFO because that seemed to be modern, dynamic, and helpful. And orthopedic surgeons weren't all that interested in the rehabilitation. Post 1994, the changes that we made were everybody gets a three-dimensional gait analysis. If the child has diplegia, even though the Aquinas or the flexed knee seems to be the only problem, the rule was look at all the levels, hip, knee, ankle, foot, and consider intervention not just at the target level, but at the other levels. And then we changed the dose. For most children with diplegia, the problem muscle was not the gastroc soleus, but principally the gastrocnemius. So we changed the surgery to a limited surgery, just recessing the gastroc, and that was much better. And then we changed the AFO to a solid AFO. So this is a gait video, and this is also one of Dr. Rang's cartoons. And this was very typical of what we were seeing in 1994 and 1995. Most of the children started off having a lengthening of their Achilles tendon, and it made them in the short term better. But a few years later, they sank down into crouch gait, which was much worse than the original Aquinas gait. So Aquinas gait is easy to correct. Crouch gait is much more difficult. So this is one of our papers which showed that 20% of the crouch gait that we were seeing was iatrogenic, and only 5% was related to the natural history. And when we made those changes based on gait analysis, our children were doing far better and we were making far fewer mistakes.
Yeah, that's very illustrative. Thanks for sharing such presentation. Actually, I like the interview. I'm enjoying so much because all the flow of the interview is leading to the next one by your answers. So our next one about the single event multiple level surgery versus stage surgery. How do you choose, and what is the number one factor to predict a smoother rehab journey?
Yeah. Um, difficult, difficult to reduce it just to one factor, but almost certainly, I think as we gained experience in multi-level surgery in Melbourne, we would be sitting around as a team, and the decisions were made by several orthopedic surgeons, always two, sometimes three or four together, and a group of physical therapists in the same room looking at the same data. And with the passage of time, the selection of the procedures and the right dose for me became easier and easier just from repetition and familiarity. And I began to realize that my younger colleagues were always looking at the individual traces and the kinematic traces and the kinetics and saying, now, what does this mean? What should we be doing? And I would be asking questions such as, where does this child live? Who's at home? And who's the community physiotherapist? So I was already in rehabilitation mode.
Mm.
Uh, the surgery is important. The decision making is important. The surgery must be precise, safe, repeatable. It must be done very, very well. That's our responsibility. But when the child leaves the operating room, having done this multi-level surgery, we also have an enormous responsibility to ensure that rehabilitation is effective. And I think that probably the single most important variable is the support that the individual child has at home and in the community, not in the hospital. We have a very good team. The nursing staff are wonderful. The physical therapists in the hospital are excellent. And for the peer and the pain management team, the orthopedic surgery, all of these components are really critical. But having put together a maximum effort, if the child goes home and rehabilitation is not well organized, not well delivered, and also well monitored, then all of the efforts can fall apart. So to me, I began to realize that the variable that we have not very much control over is the rehabilitation and monitoring, especially in the first 6 months, also the first 12 months after surgery.
So this led to create a collaboration or like spread the rehab program all over the community to make sure that your results like
Yeah.
are well taken care of after the surgery.
Yeah. So the state of Victoria, where I live and work, has a population of about 7 million, but more or less 5.5 million live either in Melbourne or immediately around it. So the majority of the population has good access to the city, but the rural population and even within the city, there are pockets where children don't have access to good regular physiotherapy. And when we opened the Gate Laboratory, we did not have a pediatric rehabilitation team in the hospital, and we didn't have access to inpatient rehabilitation. Over the years, that has changed, and it's part of our Gate Laboratory planning. If we have children having, if we have children who have a lot of weakness, who are going to need a very large program with multiple osteotomies, because The average number of procedures in multi-level surgery has been pretty consistent at about 8 procedures, 8 individual operations. But the range is anywhere from 2 operations up to, I think we've reached 16 procedures in one setting. And if we have a very major program of surgery in a child with weakness, we will identify that in advance as the team, and we will make plans in advance of surgery for periods of inpatient rehabilitation. Now, typically, that would happen at key intervals. There is generally not a lot of point in the children remaining in hospital for immediate rehabilitation after surgery because they need to get over pain, we need to manage spasticity, we need to change orthotics, and children just need to heal and recover. So for us, we have identified 3 weeks and 6 weeks as typical key periods in rehabilitation where we need full weight bearing. We need to see big improvements in progress towards return to walking and function. So typically we will identify the children that we think will need inpatient rehabilitation. We will book it as part of our preoperative planning. If we don't need it, that's fine. It's better to plan and cancel it than to suddenly find that we need it and we're not ready.
Yeah, it makes more sense. So, in your point of view, speaking about the community rehab and looking into that child and what will happen after the surgery. So, what's your simple message to the families, clinicians, so that those kids doesn't present late?
So, in our journey in each area, in each of the main areas of management where orthopedic surgeons are involved, early on in my time in Melbourne, many children came with hips that were dislocated and painful. But not only were they dislocated, within a short period of time, the femoral head can be deformed, sometimes completely destroyed, so that it's too late to put the hip back into joint. So we said, well, this is not effective. This is not good management. We need a program of surveillance. So we now have well-established programs for hip surveillance so that in our state, physiotherapists are taught which children are at risk, how to examine the child's hips, and we have recommended intervals which depend on the GMFCS level for examination and for X-raying the hips. This is popular throughout the world. The programs in Sweden are very well advanced and probably are better than the Australian programs, but we are doing our best as well. We are currently working on a program for spine surveillance because the same children who are at risk of hip displacement are at risk of a scoliosis or a spinal curvature. And again, some of these curvatures can progress very, very quickly and to the point where a simpler operation that's less invasive and more successful, we can miss that opportunity. And sometimes the deformity is too severe for any surgery. Well, for the ambulant child, we have introduced a brand new program, and we call it knee surveillance, because not only do we want to avoid children getting severe deformities, because there is a good time for surgery for ambulant children. There's too early, and there's too late, and there's just right. And one of the key identifiers of when it's just right is when the child is probably between 6 and 12 years old. That's the time where we need to look really critically. By age 6, most children are not responding well to botulinum toxin and are already getting fixed contractures. We rarely do orthopedic surgery at age 6, But this would be an example that you've kindly brought up. This is a little bit late. At stage A, this boy is 10 years old, and we would preferably prefer to have seen him a bit earlier than this, but we didn't have knee surveillance and our referral pathways were not as well established. But this is certainly the latest that we would like to see him. GMFCS3, and you can see the flexion contracture at the knee and the mild equinus contracture at the ankle. So he goes to the gait laboratory. We conduct multi-level surgery at the level of the hip, the knee, the foot and ankle, and it takes quite a while to recover. So it's 2 years before the second photograph was taken at B, and everything is straight and everything is well aligned. And then we follow these kids right through and we conduct a 5 and sometimes 10-year follow-up. If you judge by the degree of the amount of hair on the lower limbs, you can see that A was pre-pubertal, no hirsutism. At B, the pubertal growth spurt has just started, and we much prefer to do our surgery before the pubertal growth spurt because things can go badly wrong during puberty. And then we continue to manage this boy by observation, but we were able to determine that the correction was lasting after A and by the time he got to B, and then between B and C, no further surgery, limited amounts of physiotherapy were required, limited use of orthotics. Essentially, if we do our surgery at the right time and get things balanced in the sagittal plane, it is for at least half of our children, no further surgery will be required. Some children will regress a little bit during the pubertal growth spurt, and some additional surgery may be required. So some people have criticized the concept that it's not single event multi-level surgery, and that is a reasonable criticism. So maybe a better term is just multi-level surgery, and we do advise both the children, the families, and the community therapists that surveillance should continue until at least until growth is over, because there will be in about 50% of children some new deformities, and new interventions may be required, usually much smaller and usually simpler, but they may be required.
Okay, so is this leading to this key concept about the height velocity?
Yes. If you just go back to the previous slide on the distal femoral epiphyses, so this one leads into the next slide. So these slides were produced by a colleague of mine from the Shriners Hospital in Sacramento, California, Dr. Vedant Kulkarni, and I'd like to really recognize his contribution. So this shows how that the distal femoral physis is growing, and in children it doesn't grow at a linear rate. It always grows pretty quickly, but it grows at the pubertal growth spurt much faster. And the concept is that if we see children with small flexion deformities at the knee, where the word tether is written, we can do a small procedure called guided growth, and then we could harness the remaining growth to slowly straighten the knee. So if you proceed to the next slide, please. So this is based on knowing in the pink slide on the left, the pink line is the rate of growth in height and known as peak height velocity in girls, and the blue line in boys, peak height velocity in males. And there is some variation, but this is very typical. There are 2 years or 3 of very rapid growth before the physes close and growth is over. So ideally, we need to see children just before that pubertal growth spurt, and we certainly want to see them in the gait laboratory before they go through puberty, because if they have for two reasons. Deformities are likely to increase during that growth spurt. And secondly, some of the interventions, such as guided growth, only work during the episode of PHV, peak height velocity.
It's very demonstrative, and thanks for explaining that. This will move us to the next question. And you think what outcome matters most? Is it the GMFCS or the energy cost or like the caregiver burden, or how does it work?
Very important, really important question. Difficult to give a short answer to. I think all of the outcome measures are ideally they can each contribute a different aspect. Energy is important. I had a lot of interest in measuring the energy cost of walking. Kinematics and kinetics are important because we base some of our planning on those. Questionnaires in which the patient and their family report their quality of life, really important. My colleagues in Toronto have developed some of the best patient-reported outcome measures, or PROMs. There's one for the non-ambulant child called the CP child, and then another one called the GOAL, which is for the ambulant child, and these are superb tools. But I once had this conversation with one of the leading pediatric orthopedic surgeons, who was one of my mentors and one of the foremost educators. His name is Dr. Lynn Staley, sadly no longer with us. And I asked him what he thought about outcome measures. And he thought, and then he said to me, in the first decade, it's all about function. And he said the children and the parents, typically the children with diplegia, have delayed acquisition of skills. So they're slower to stand, slower to achieve walking, very slow to achieve higher skills like running and jumping. Sometimes they don't gain those at all. But function is really important in the first decade. And probably we can do most in the first decade to improve function. And then he said to me, in the second decade, remember that these young people are becoming teenagers, and their self-image and the cosmesis of their lower limbs and cosmetic things become very important. And if you can correct a deformity and give a child a better body image, they will thank you for that. I remember proving this in my own experience. I had a child with mild diplegia. She had significant in-toeing, but her contractures were mild. She could already walk independently. She could run. She was very physically capable. And she came to the Gate Laboratory, and we worked out that she could benefit from femoral derotation osteotomies and some limited muscle surgery. But it was going to be a large amount of surgery for because already her function was up here, the gains were going to be maybe 5%. And I found it very difficult to explain to her and to her family what realistic expectations were. But she went through surgery, wonderful child, wonderful family, really supported her. She did a great rehabilitation. And when she came back, she was one of only 3 children that I have treated whose gait pattern fell within the normal range. So her gait pattern, as long as we covered up the scars on her legs, when she wore pants or a long skirt, you could not tell that her gait was different to her peers. So at my final interview with her before I discharged her from our hospital, I said, was it worth it? And she looked at me and said, Of course it was worth it. Before I had the surgery, I couldn't hide the way I walked from my classmates. Now they accept me as as one of them, and I no longer am embarrassed about my gait. So first decade function, second decade cosmesis, and then Lynn Staley said to me, after that, it's all about pain. And I agree. For the adult, the literature now shows that the single biggest concern for young adults with cerebral palsy is not spasticity, not the cosmesis of gait, but it's quality of life, which is largely predicated on pain. So, first decade, improve function. Second decade, improve appearance. Third decade, do your best to treat and manage anything that causes pain.
Thank you very much. This is very conclusive outcome, actually. And do you think what is the complications that is mostly under discussed with the families? Like, is it recurrent deformities or overcorrection or weakness?
I would put both pretty equal. Recurrent deformities, it's really important to and we need better predictors. We're assembling a database that gives us better predictors, and it's to do with the severity of cerebral palsy, whether it's diplegia or hemiplegia, the age at surgery, which if we some I mean sometimes we do need to do age surgery at younger age, but the number of years of growth remaining is a good predictor of the risk of a new deformity. It's very important because multi-level surgery is emotionally, financially, socially, there are high costs for the child and for the family. And it would be very remiss if we don't give an accurate estimation of the risk of needing further surgery. We might think the further surgery is quite small, but any surgery that requires a general anesthetic, an admission, a new incision, and a rehabilitation for the child and the family, that's not small. That's another big thing. So being aware of the potential for new deformities or recurrent deformities, very, very important to inform the family.
Yeah, thank you. And this would be our last question. And how do you see the future of the outcome measure to make a better outcome measures in this era of like high quality cameras, especially for your lab gait analysis, and also for AI, which can do the analysis for the
Yeah,
gait. Also, it can help and to be included in the surveillance if you want to early detect the cases.
sure. I've now retired. I'm still involved in research and teaching, but I don't do surgery anymore. But in my lifetime, the care of these children has changed dramatically. It's improved, it's more predictable. Our success rates are higher. We're doing much better. But there's so much more, and there will be further developments and things that I can't even anticipate. So with gait analysis, one of the weak spots is placing markers on the child's limbs, and the camera is recognizing the markers. I think within a few years, we will have better markerless systems and that our gait analysis will be more accurate, quicker, easier, cheaper, and more widely available. The development of wearable technology is going to transform both gait analysis and understanding what happens at home. I've already done some research with little monitors, activity monitors with children to understand better what they do at school and what they do in the home environment. But wearable technology will continue to develop and get better, less invasive, cheaper, and give us more and more and more information. With regards to outcome tools, we have the first thing is that we should use our current tools more frequently in a more standardized way. So we have simple scales like GMFCS. That's not an outcome measure, but we have a simple scale called the FMS, which is an outcome measure. And we need to record that prospectively at every time we meet the child and meet the family. And by assembling larger databases with standardized measures, we need to understand both natural history better, and we need to understand the history post-intervention better. For that, we need to make standardized measures at regular intervals and build databases and then turn it over to AI, which is going to help us learn things that we can barely understand at the moment. So I think the future is exciting.
Thank you so much. Thanks for your time for this really interesting interview, and we have learned a lot. And thanks for sharing all those materials and presentation. It is very illustrative, and we also looking forward to learn more and more from you and know the future, how it will be.
Well, thank you for the opportunity, and your questions were, I believe, extremely focused, very well-informed questions. So it made our conversation, to me, interesting and dynamic, and I thank you very much.
Thank you. Have a good day, sir.
You too. Thank you.